Hello, and welcome to the ICP Waveform Analysis 6-Minute Synapse series. In this session, ICP Waveform Analysis, we will cover the basic concepts of interpreting your ICP waveform, including what each wave represents and what it can look like when your patient has lost compliance. My name is Kenna Seal, and I'm a neuroscience nurse and clinical specialist for Natus. So let's go over a little bit of background before we dive right into waveforms. Why do we worry so much about intracranial pressure, and why is it something that we watch so closely in our patients? It's because our brain lives inside this box, the cranium, which is essentially non-expandable and has a finite amount of space inside of it. But I don't want you to think about it just as one big compartment. Our dura wraps tightly around the brain. It is tough and it doesn't stretch well. And our dural folds create these compartments, kind of like a box with dividers. Our falx cerebri splits the box right and left, and our tentorium splits the box top and bottom. Why is this important to know? In cases where you are monitoring ICP but CSF is not freely circulating, you can have what is known as a compartmentalized increased intracranial pressure, meaning that the pressure in one area of the brain can be higher than in another area of the brain. This is often because of these tough dural folds. Now I'm going to take you all the way back to nursing school for a minute and breeze over the Monro-Kellie hypothesis. The Monro-Kellie hypothesis says that there are three things that live inside this box: brain tissue, blood, and cerebral spinal fluid, and they're allowed to take up a certain amount of space. If any one of these things should start to increase in volume, then the other two must decrease in volume to compensate and maintain a normal ICP. When a category grows slowly, like a chronic subdural hematoma or a slow-growing mass, we can more readily compensate and are less likely to present with an increase in ICP. If something were to take up more than its allowed space quickly, such as a subarachnoid or intracerebral hemorrhage, there isn't any time to adjust volumes, and these patients typically present with an increased intracranial pressure. But ICP is not linear. It's not that you add 3 mLs of CSF or blood and your ICP goes up 3 millimeters of mercury. We have some space inside this box, and initially we can add volume without increasing the ICP. If we continue to add volume without compensation, then our box becomes full and we reach a point where we add just a little bit more volume and our ICP increases rapidly. In neuro patients, this is often referred to as compliance. The definition of compliance is the ability to add volume without increasing ICP. It's the available space inside of that box. The more compliant a cranium is, the more volume we can add without increasing ICP, and the less compliant cranium is going to be at risk for increased ICP, even with adding only a small amount of volume. Our ICP waveform can give us an idea about who is at risk for secondary injury from decreased compliance and increased ICP. So now let's get into the analysis. What should your ICP waveform look like? Well, it should look somewhat like a descending waterfall with 3 waves, P1, P2, and P3. You can see in this strip that the P1 is the peak wave, and then P2 and P3 follow. P1, the first wave, should be the peak wave. It's the big push of blood flow into your brain. Most of this wave originates from the choroid plexus inside of the ventricles. Because the P1 wave is associated directly with blood flow, you can see a peaked P1 wave with a high systolic blood pressure and a dampened P1 wave with a blood pressure that is inadequate. Your P2 wave is your tidal wave. That is the wave you want to be watching closely because it shows us how compliant the cranium is or how much space we have in that box. It is said to represent the stretch of the parenchymal tissue. You want to make sure that it stays below the level of the peak of P1. And your P3 is your dicrotic wave and indicates the reflective pressure when your aortic valve closes. Its amplitude is dependent on the volume of CSF circulating. In these drawings, the top figure is a very compliant cranium, or a box with a lot of space in it. The P2 is well below the level of the P1. The second drawing, however, is representing a non-compliant cranium. The P2 wave is above the P1 wave, indicating a loss of compliance or a box that is out of space. If there is a further increase in volume, it will result in a markedly higher intracranial pressure. When we see the P2 start to become elevated, we know that our patients are at risk from secondary injury as a result of a high ICP and decreased blood flow. This is an example of what it looks like in a real strip. You can see that the P2 is elevated above the P1, indicating a loss of compliance or a box that is out of space. You can also see that if the P2 were to decrease or drop down, you would have that perfect descending waveform discussed in previous slides. Here are some more examples of non-compliant waveforms. As you can see, these non-compliant waveforms can look very different between patients. There are many factors that can affect how a waveform looks, and it can take practice to be able to discern the individual waves in an ICP waveform. Sometimes it can be hard to decipher the P1 from the 2 or 3. The takeaway from this should be that when we see the P2 start to become elevated, we know that our patients are at risk from secondary injury as a result of a high ICP and decreased blood flow. So what can we do at the bedside when we see this? I like to say that the best thing we can do is optimizing our patient's care, making sure they are positioned correctly, not overstimulated, adequately sedated with pain managed, and afebrile. We still need to be repositioning and providing oral care, etc., but we need to be mindful of unnecessary overstimulation. For more information on this topic, please refer to the ICP Management Synapse. Lastly, there are a few situations in which your ICP waveform may be dampened. If you have a patient with a craniectomy, they no longer have that closed box. The closed dura will help provide some waveform, but it may be hard to read. The same with the pneumocephalus because of the airspace inside the cranium. As the pneumocephalus absorbs, you can expect the waveform to improve. And in the presence of a subgaleal drain, you may see not only a dampened waveform, but a negative ICP because of the reverse pressure to the tissue. Once the drain is removed, the ICP and waveform should correct itself. This is an example of an ICP waveform after a hemicraniectomy, meaning there was a piece of the skull removed to help prevent secondary injury and herniation from increased intracranial pressure. You can see that there isn't a discernible P1, P2, P3. It is important to note that a patient with a bone window or craniectomy can still have increased ICP, decreased blood flow, secondary injury, and herniate. It is imperative for the bedside nurse to be able to evaluate their patients fully, and the ICP waveform can be an important part of that. The ICP waveform gives us the clues to when our patient may be heading in the wrong direction. The nurse that can use this as part of the evaluation can help prevent secondary injury, and potentially the patient could achieve a better outcome. Here is a list of my references. Thank you for joining this presentation. If you have any questions or comments, please feel free to reach out to me at kenna.seal@natus.com.